Okay, picture this for a second. You've just gotten over a cold, maybe finished some antibiotics a couple of weeks back. Now, if someone knocked on your door and asked, exactly which days did you take that painkiller, or do you still have the box for those antibiotics? Could you remember for sure? Seems simple, right? But getting a real handle on what medicines people actually use in the community, well, that's a huge challenge for public health. Welcome to the deep dive. Today, we're going to peel back the layers on how researchers gather this really vital info about medicine use in households. We're diving into a key review that looked at how these surveys are done, and honestly, some of the findings about the methods and the problems might surprise you. Think of this as your inside look at the science behind those public health headlines.
Exactly. And the main source for our deep dive today is this really comprehensive systematic review by Bertoldi and colleagues from back in 2008. They looked super closely at the methods used in household medicine surveys between 1995 and 2008. And these aren't just, dry academic exercises. These studies are fundamental. They help us understand access, cost, barriers, all from your perspective, the person actually using the medicine, and the data. It feeds directly into shaping better health policies.
That's such a good point because we often think, okay, medicine use equals prescriptions from doctors, pills from the pharmacy. But these community studies, the ones done right in people's homes, they offer something, well, much richer, don't they? It's about the lived experience, a more human picture than just looking at prescription numbers. And like you said, this info helps shape policy, check how health systems are doing, even track diseases.
And that leads us to a really big challenge globally, but it's especially tough in low and middle income countries. Often, they just don't have those big integrated computer systems to track everything smoothly. So researchers, they often have to rely really heavily on talking directly to people, doing interviews,
Yeah.
which is great for getting firsthand stories, but
But it brings in that big problem you mentioned, reporting bias.
precisely. Reporting bias,
Yeah.
what someone says they did versus what really happened. Maybe they forgot or misunderstood or just wanted to give the right answer. And that's exactly why digging into the methods is so, so important. How the questions are asked matters immensely.
Right. You need good methods to trust the results. And that Bertoldi review sounds like a key piece for understanding those methods. How did they even tackle looking at all that research? You said it was comprehensive?
Oh, it was a mammoth task.
Yeah.
They started with, get this, over 4,800 papers initially. Then they really narrowed it down, focusing on 61 studies that met their specific criteria, basically, household-level data between 1995 and 2008. So it gives us this really valuable snapshot of how things were being done during that time.
Wow. Okay. So what were some of the big takeaways? What did the landscape look like then?
Well, first off, geography. A lot of the studies, nearly two-thirds, about 64%, were actually done in Europe and North America.
Okay. So if most studies are from those regions, does that mean we're kind of flying blind when it comes to understanding medicine use elsewhere, like Africa or Asia? What does that imbalance mean?
It absolutely points to a data gap, a real imbalance.
Yeah.
And yeah, if policies are based on data, mostly from wealthier countries, they might not fit the needs of people elsewhere. It's a big issue for health equity, for sure. Then, looking at how they did the studies, most use what's called a cross-sectional design.
Like a photo, just
Right.
one moment in time.
Exactly, a snapshot, not tracking things over weeks or months, which is efficient, like you said, but you do miss how things change.
Okay. And did they talk to a lot of people? How did they actually collect the info?
Yeah, sample sizes were generally pretty good. Two-thirds had over 1,000 people involved. But here's a key thing for you, the listener, how they collected it. Over 80% used face-to-face interviews, sitting down and talking to people directly.
Face to face. That sounds good for getting details, but I guess it has its own issues too.
It does. Great for depth, but you have to think about potential interviewer influence or people feeling they need to give socially acceptable answers. It's a trade-off.
Okay, so if you're sitting face to face, what's the first big hurdle when you just ask, so what medicines have you taken recently? Where does memory come in?
Memory. That's probably one of the biggest methodological knots to untangle. It comes down to defining the recall period.
Recall period, you mean how far back they ask you to remember?
Exactly that. How far back are you asking someone to think? What did you take in the last 24 hours versus the last 2 weeks versus the last 6 months? Your memory is going to be wildly different, isn't it?
Oh, definitely. I struggle to remember lunch sometimes, let alone pills from weeks ago. So what did they find was the most common time frame?
The review found that 14 or 15 days, so about 2 weeks, was the most common recall period used in these studies. But, and this is really striking, the range was huge. Some studies asked about just 1 day, Others went back as far as 2 years.
2 years. Wow. Okay, that variability seems problematic. Why such a massive difference, and what does that do to the data?
It raises huge questions about comparability, doesn't it?
Yeah.
And it massively impacts the results. The key thing for you listening is, when you see stats about medicine use, always check that recall period. Because as we'll get into, changing it from, say, 15 days to 30 days can totally change the picture of how common something seems. A health issue could look bigger or smaller just based on that time frame.
That's fascinating and a bit scary, actually. Makes you question the headlines sometimes. So, given memory is so unreliable, how did these studies try to, check if people's answers were accurate?
Good question. They looked at validation methods too. And one quite clever approach, used by almost 60% of the studies, was simply asking to see the medicine packaging.
Ah, like, can you show me the box?
Exactly. It's tangible proof the medicine was likely in the house. Since people often keep these things, it's a practical way to double-check.
Okay, that makes a lot of sense. But what about prescriptions? Did they ask to see those too? That seems like even stronger proof confirming why it was prescribed and when.
You'd think so, logically. But kind of surprisingly, only about 15%, much smaller number, actually asked to see medical prescriptions.
Only 15%.
Hmm.
Huh. Why the difference, do you think? Is it harder to get people to show prescriptions?
It could be privacy concerns, or maybe people just don't keep them as readily as the boxes. But it does highlight a trade-off. Packaging shows presence, but the prescription links it to a diagnosis and date, potentially offering, much better accuracy, especially for certain types of drugs.
Okay, so let's really dive into this recall problem. Why is it so hard to remember accurately? You mentioned forgetting things.
Right. Interview data is just inherently prone to issues. There's imprecise recall. You just completely forget you took something. Or it's incomplete. Maybe you remember the drug name, but not the dose, or how many days you took it for. And sometimes people just misunderstand the question being asked.
Yeah, I can see all of that happening easily.
And the review really hammers home how much the prevalence rates. The percentage of people using a medicine depend hugely on that recall period. They cited a study from Pelotas in Brazil. With a 30-day recall, antimicrobial use was 7.3%. Change that to a 15-day recall. It drops to 5.4%.
Wow, same population, just asking about a shorter time.
Exactly. Another one, Porto Alegre. Overall medicine use was 54.5% with 15-day recall, but only 35.5% with a 1-day recall. It starkly shows how that time frame shapes the numbers you get.
That's a massive swing. It feels like you could almost choose your result by picking the recall period. And it can't just be the time frame, surely. Our own ability to remember must matter too.
Absolutely. Things like getting older or taking lots and lots of different medicines both tend to decrease how accurately people remember. And here's a really interesting finding. Self-prescribed medicines, the stuff you buy over the counter yourself, are particularly hard to recall accurately. That Kenya study they mentioned. It found a 60% underreporting of self-prescribed stuff when they used a 2-week recall compared to just 1 day.
60%, that's huge. So people just forget the painkillers or cold meds they bought themselves much more easily?
It seems so. Whereas medicines you take regularly, maybe for a chronic condition like heart medication, those tend to be recalled more accurately, at least over shorter periods.
Okay, I'm definitely convinced remembering is tricky. So for the researchers, is there any kind of best or ideal recall period to aim for?
Well, the consensus from the review is basically no single ideal period fits all situations. It really has to depend on what the study wants to find out and also, frankly, the population's ability to remember things. But if the goal is comparing data across different studies, trying to build that bigger picture, then that 14-15-day period seems to be a common benchmark just because it was used so often in the studies they looked at.
Right, a common reference point helps. Okay, so beyond when you ask about how you ask seems critical too. What about the interview method itself? Face-to-face versus phone or mail?
Yeah, the how is crucial. The review generally recommends face-to-face interviews as the way to go, especially in lower and middle-income settings. The big reason, response rates, just significantly higher. That Brazilian study saw double the responses compared to sending surveys by mail. Plus, face-to-face gets around problems like people not having phones or maybe struggling with reading a written survey if literacy rates are lower.
Okay, so face-to-face helps get more people involved and overcome some practical hurdles. But once you're talking to someone, what about the actual questions? The wording must be super important.
Hugely important. Clarity is king. Using simple language, but still technically correct terms, is essential. People can easily get tripped up by medical jargon. And another big thing, people often just don't report medicines they see as, well, less important.
Less important. Like what?
Things like everyday painkillers, allergy meds, cold remedies, vitamins, natural products, even topical creams. One study specifically noted people often fail to mention medicines for pain, allergies, colds, or weight loss. They just don't think of them in the same way as, say, a prescription heart medicine.
Ah, so it's not just forgetting, it's actively filtering out things they don't think count. How do researchers get around that?
They need to specifically ask about those categories, prompt people directly. What about pain relievers, vitamins, anything for a cold?
Hmm.
The review also touched on question types. Open-ended questions like, what have you taken, are generally good for overall use. But sometimes, using a checklist for specific types of drugs, like maybe different classes of painkillers, can jog people's memory. One study saw a 5% jump in reported use with a checklist. Another saw 6% just by showing pictures.
Pictures. Simple but effective, I guess. Okay, what about situations where the person themselves might find it hard to answer? I'm thinking particularly about older adults.
Yes, that's a really important consideration, especially for vulnerable groups. For elderly people, maybe with memory issues or taking many medications, getting information from a relative or caregiver, what researchers call a proxy, is often much more reliable.
Right, relying only on the elderly person might give you an incomplete picture.
Exactly. And because older adults often use more medicines, excluding them or getting inaccurate data from them can lead to underestimating overall medicine use in the population. Yet the review found only about a quarter of studies that focused just on the elderly actually used information from proxies. It suggests a gap.
Hmm.
And it also raises the question of transparency. Studies really should state clearly if and how they used proxy information.
Definitely needs transparency. And let's quickly circle back to checking accuracy, the validation part. You mentioned asking to see packaging was common.
Right, 59% did that.
But asking for prescriptions was much rarer, only 15%.
Correct.
It just reinforces that these are really useful tools, tangible ways to back up what people are saying and boost the data's accuracy, moving beyond just relying on potentially faulty memory.
Absolutely. And another area needing real clarity is just defining types of medicine use. Terms like regular use or chronic versus acute. They sound straightforward, but they can be surprisingly fuzzy.
Fuzzy how? Give me an example.
Okay, think about an oral contraceptive pill. Is that used for a chronic disease? Technically no, but it's taken long term. Or what about a long course of antibiotics to prevent an infection? Is that chronic or acute? If different studies define these terms differently, it makes comparing their results really difficult. The review actually suggested maybe using terms like habitual use or use without a set stop date might be clearer than relying on treatment duration alone.
Yeah, habitual use sounds less ambiguous. Okay, so once you know what medicines people took, you need to classify them, right? Put them into groups like painkillers or antibiotics. Is that straightforward?
Not always,
Yeah.
because the reason for taking the medicine, the indication really matters. Think about aspirin, acetylsalicylic acid. You could be taking a low dose to prevent blood clots for your heart or a higher dose for a headache. Same drug, different purpose, different pharmacological group, so you need to know why it was used. And here's a major issue the review found. Nearly half the studies didn't even say which classification system they used.
Half. Didn't mention the system, like the ATC system.
Exactly. Like the ATC system, that's the anatomical therapeutic chemical classification, a sort of global standard.
Yeah.
If studies don't report using ATC or some clear system, comparing their findings becomes almost impossible. How do you know if they're classifying drugs the same way?
Wow, that lack of standardization seems like a huge barrier to getting a clear global picture.
It really is. And one final, maybe subtle but really important point the review highlighted, your denominator.
Denominator, as in the bottom number in a fraction? How does that come into play?
It's about what you're counting as your base. Are you reporting the percentage of people who used a certain drug, or the percentage of all medicines mentioned that fall into a certain category? It can give you very different impressions. Bertoldi et al. Gave an example. 16.5% of all the medicines reported were non-opioid analgesics, basic painkillers, but 32.2% of the people interviewed had used at least one non-opioid analgesic. See the difference?
Ah, okay, so are you talking about the share of the medicine market or the proportion of the population using it?
Precisely. And if researchers aren't crystal clear about which denominator they're using, their results can easily be misinterpreted. It really underlines the need for transparent reporting in every aspect.
Okay, so we've really gone through the nuts and bolts here. We've seen how tricky it is for researchers to figure out who's taking what medicines, Memory issues, people not reporting certain drugs, the challenge of asking the right questions, checking the answers. It's complex. Understanding all these methods is so important if you want to make sense of public health data.
Absolutely. And the bottom line is, better methods mean better data. Better data leads to smarter, more effective health policies and just a clearer view of what's happening with public health. Sure, some differences in methods are okay depending on the study's aim and where it's done, but more standardization in key areas like recall periods, definitions, classification systems like the WHO pushes for with its standardized tools, that would be a huge help for comparing data globally.
Makes sense. But you also mentioned a gap that still exists.
Yeah, a really important one. We still don't have a lot of data on how reliable and valid the questionnaires themselves actually are. Are these tools truly measuring medicine use accurately? There is still some uncertainty there.
Right. We need to know if the measuring stick itself is accurate.
Exactly.
Okay, so wrapping this up, maybe a final thought for our listeners to chew on.
Sure, considering how much relies on this data health policies, understanding disease, our own well-being, what fundamental changes could we make? Maybe starting today. How could we ensure the information coming directly from you, the consumer, is as accurate and complete as possible? To really capture the messy reality of how we all use medicines. Maybe it's technology, like a personal medicine tracking app, or maybe just better conversations between patients and doctors.
Yeah.
Something to think about.
Definitely something to think about. Thanks so much for breaking all that down for us.
My pleasure.
And thanks to all of you for joining us for this deep dive. We hope you walk away with a clearer, maybe more critical eye for the science behind measuring medicine use. Until next time.